Welcome to the recorded version of Hospital to Home, part of the Family Caregiver Support webinar series brought to you by the American Society of Aging and a generous sponsorship from Home Instead Senior Care. Okay, our presenter today is Lakeland Hogan. Lakeland is a gerontologist and caregiver advocate for Home Instead Senior Care. She works to educate professionals, families, and communities on issues older adults face. Lakeland is a doctoral candidate at the University of Nebraska, Omaha, where she is studying social gerontology. She has a Master of Arts in Social Gerontology and a Master's in Business Administration from UNO. Lakeland has professional experience in the private and public sectors of senior care services. She has worked on special projects for UNO's Department of Gerontology and the local area agency on aging. Lakeland serves as Vice President of the Board of Directors for the Dreamweaver Foundation and is active in the Alzheimer's Association's Walk to End Alzheimer's. Lakeland has a passion for helping others, especially aging adults and their families. And with that, I'd like to turn the floor and the presentation over to Lakeland Hogan. Thank you for being here and presenting today, Lakeland.
Thank you so much, Steve. And thanks to all of you again for tuning in today to join me for an important topic. We'll be talking about the transition that older adults often face after going home from the hospital. This topic has really been kind of on the hot topics list over the last couple of years, especially with the hospital readmissions programs that is starting to penalize hospital systems when older adults readmit to the hospital, especially those otherwise preventable readmissions have been a really hot topic. And so today we're going to take a look at hospital to home and that transition through the lens of a professional and what we can do to help people through that discharge process and really make that transition as smooth as possible, whether that's back home or to a senior living community. But this can be a vulnerable time for an older adult and a stressful time for family caregivers. So as professionals, attending webinars like this and building up your arsenal of resources can really help older adults and their families through that transition home and help make it as successful as it can be, and hopefully then prevent any hospital readmissions. So before we get started, I thought I would go over our objectives here on the first slide. By the end of today's webinar, it's my hope that you will learn about the importance of planning ahead for discharge. We're also going to be talking about the risk factors or the drivers that could cause a readmission. We're also going to talk about key steps that families can take to help with that successful transition home. And then finally, I'll share some resources with you that you can pass along to the older adults and families that you work with on a regular basis. So I wanted to start with some considerations for older patients when we talk about this topic of the transition home from the hospital. So there are several considerations for older patients, many of which can put them at risk for those readmissions or pose challenges in the compliance of their discharge plans after a return home from the hospital. So the first consideration is really that we need to just keep in mind older adults are often the largest consumer of health care in the U.S. So people 55 and older account for over half of the total health spending in the U.S. So when we talk about this population, it is very common for them to be transitioning from the hospital back home, as those admissions to the hospital can be caused by a variety of reasons. And our goal as healthcare professionals and professionals in the field is really to get them back home in their living environment as safely as possible and, again, to prevent that readmission. But we do know that changes or limits in an older adult's physical or cognitive levels, especially their levels of functioning, could really impact their transition from hospital to home. So we need to be acutely aware of those changes in their abilities, both physically and cognitively. We also need to be mindful of their recent history of frequent health visits and their recent history of health interactions. I think we all probably worked with an older adult or two who we would consider frequent flyers, or those who return to the hospital, the health clinic, or the ER regularly. And so those can be what we would consider high-risk patients. And so we definitely want to make sure that we're taking into account past history in terms of their health care visits. Also, we know that uh, comorbidities can complicate a return home or could cause a readmission. One common comorbidity that we see quite often in the aging population is diabetes, and challenges with managing that for some could cause readmissions, just as one example. And then older adults are often taking multiple medications, which we know can put them at risk in various ways, but especially in a transition home from the hospital, oftentimes their medications will change or they'll be told to discontinue a certain medication. And if their medication is not reconciled, or if they don't have somebody at home assisting them to go through that medicine cabinet, it could cause some problems with their medication routines. And we'll talk more about that later. And some older adults can no longer drive or might have to temporarily stop driving due to the reason for their hospitalization. And so transportation needs are common among the older adult population, not only in their transition home, but also in those follow-up appointments that are so critical for preventing those readmissions. And we also know that many older adults need assistance with their activities of daily living, or those ADLs, and it might be temporary assistance after returning home or more of an ongoing need for assistance. And family may or may not be available or may not feel comfortable assisting with some of those ADLs. And then speaking of family, some older adults lack family support, or maybe due to distance. Possibly their family members live across the country, or their adult children work full-time, or are not in a condition themselves health-wise where they can contribute to the care needs of their aging loved one. But we do know that family support is really, really important, and so we're going to talk about that later on. And then for those older adults that live at home, we know that those individuals need additional consideration because their safety and security at home is of utmost importance, especially in regards to their living environment and making sure that that is safe for them to transition back to. And then finally, the healthcare system can be very complex and confusing for older adults, and so they might need extra assistance navigating various health systems, making those follow-up appointments, and so forth. And then we also need to consider some additional factors, kind of from a holistic perspective. We also need to consider the cognitive, behavioral, functional, and social aspects of older adults that could put them at risk for readmission or create some challenges during that transition home from the hospital. So if we consider the area of cognition, we may commonly see confusion among the older adult population. This could be caused by a variety of reasons. Could be caused by delirium, sleep deprivation. It could also be due to cognitive issues, possibly related to Alzheimer's or other types of dementias. And then we have to look at the behavioral factors. So behavioral issues could arise, such as anger, irritability, agitation, and sadness. These could be symptoms related to cognitive issues such as Alzheimer's or dementia, but it could also be coming about due to a loss of independence. And maybe that loss of independence is very hard for them to cope with, and so you may see them exhibiting some behaviors such as anger or irritability, maybe even sadness, or which could lead to depression. But this loss of independence could be due to the medical issue that they're being hospitalized for, or decline in their cognitive or physical functioning. And then when we look at functioning, of course, we need to be aware of changes in their physical functioning. Perhaps it's limited permanently or temporarily. They might also experience sensory limitations, and they might also be experiencing pain due to the reason that they're in the hospital. So we definitely need to be mindful of that. And then from a social standpoint, it's important to consider their social network. I mentioned, or their support network, social network. I mentioned how earlier family can be so crucial for this transition home. And for some, they may lack that family support, or lack family members that live locally that are willing or able to assist, but they also might lack resources or be limited in their knowledge of the resources available to them, which can pose an issue. But we can also sometimes see older adults socially withdraw. They might also have become depressed due, again, to maybe their functional limitations, their reason for hospitalization, and this can impact, their appetite and their attitude towards recovery, and again, could put them at risk for a readmission. So when we take a look at older adults in this transition from hospital to home, we really need to take into account this holistic view. It's not just the medical that we need to focus on. We really need to take a look at all of these dimensions. So when we consider, all of these considerations for our older patients and these holistic factors, we take all of that into account, and you add on top of that a transition home with sometimes complicated discharge plans or guidance from healthcare professionals. It can make the transition home complex, which also can make readmissions complex. And so we're going to talk about the complexities of readmissions on this next slide. And as I mentioned earlier, this topic of readmissions is very timely, especially as healthcare systems work on strategies to reduce readmissions within their hospital systems. And we know that that readmission window is really that 30-day period after being discharged. So when we think about the reasons for those readmissions, we know that not all of them are avoidable. So some of the reasons that people might go back to the hospital would be for a previously scheduled treatment. We also know that some people, when they are admitted to the hospital, are too weak when they are admitted, and because of weakness, they were unable to have all of the treatments that they needed during that hospitalization, so they might have to go back and be readmitted to finish the medical treatment that they are in need of. Others might be discharged for one condition or illness, then they might transition home and then come back to the hospital with a completely unrelated incident. So to give you an example, I once had an older adult I was working with that was discharged after having a hernia surgery, but was readmitted 2 weeks later when he fell and broke his hip. He was walking in the park and it was kind of a freak accident. So those two incidences were virtually unrelated, and so again, readmissions can happen in those types of contexts as well. And then, so we know that new illnesses and accidents can happen as well. So all of these are not avoidable, but many readmissions are avoidable, and those are really the ones that we need to work with the patient in terms of helping with that smooth transition home in hopes to reduce those readmissions. So when we take a look at this topic of readmissions, next I'm going to talk about readmissions from really the provider perspective and then the patient perspective. So the information on this slide and some of the following slides is information that comes from a 2013 Robert Wood Johnson Foundation report. It's called The Revolving Door. It's a report on U.S. hospital readmissions. And really this is a data analysis of Medicare data and then also patient stories and healthcare provider stories. And this report, I realize, is from 2013, but it really does contain some information that is still very relevant. As I go through the next two slides and talk about some of the drivers for readmissions, I do want to acknowledge that many health systems have taken steps forward to improve their readmission rates, and so many have found solutions to some of these drivers that I'm going to go over, but there are still hospital systems out there who are working on these types of challenges. So again, I'm going to start with the provider perspective and talk about how they kind of perceive some of the drivers of readmissions. Providers talk about how discharge decisions are often complicated, and there are certain reasons for hospitalizations, and some reasons have higher readmission rates than others, which can impact discharge decisions and how long the patient stays in the hospital. We also know that there are providers out there that still feel pressure to discharge their patients quickly, and sometimes this pressure may not always be in the best interest of the patient. And then we know that sometimes there's a lack of clarity regarding who is responsible for the care situation. There's oftentimes many providers involved. We know older adults will often see, the hospitalist and the cardiologist, many providers throughout their time in the hospital system. And so this is where that multidisciplinary team approach can be so important, because this is where communication breakdown can happen in the hospitalization of an older adult in the discharge process. And then there's not only do doctors sometimes feel pressured to discharge the individual, but they're also sometimes feeling pressure from the family or the older adult themselves. Oftentimes, the patient really wants to go home. Sometimes the hospital is not always the most fun place to be, so they'd rather be at home in their own bed. They think that they're okay to manage on their own, when in reality they might not be. But again, sometimes there is that pressure that comes from the family. And I did mention how communication issues can be complicated, or communication can be complicated, causing issues when coordinating plan for discharge and even post-discharge care. This can occur between the provider, the families, the patient themselves, and even the care community or rehab setting if they go to one of those types of care facilities. And then patients are not always honest, and this can pose a problem. I'm sure that you've probably encountered this in your work with older adults. They may not be truthful about their home situation, and some of this might be due to the fact that older adults tend to be very private, or they might be embarrassed about their lack of resources, or they really just want to get home, and so they're telling you what you want to hear to make that happen. So we do need to be mindful of that. That's not always the case with older adults, but we want to make sure that we really understand their home situation, again, with the hopes of providing the older adult with the support they need to prevent that readmission. And then patients might not always have the means to meet their basic needs when they are transitioned home. And so as you can imagine, that could be putting them at risk for a readmission. So they might need assistance finding resources to help meet those needs post-discharge. And then if we look from the patient perspective, many patients will sometimes feel that they're discharged too soon. They might feel that the timing of their discharge was motivated by various factors. And some patients might again, want to be discharged, and so they're willing to leave the hospital even if they're not feeling 100% or to a place where they can continue to recover at home. Oftentimes, patients feel that they don't always understand their discharge instructions. They might be tired, afraid, they're feeling out of their element in the hospital. And so oftentimes providers can only spend a short amount of time providing instructions on care, or they're handed some reading material to help them understand their illness, but patients don't always feel that that is enough. So we need to be mindful of helping older adults really understand those instructions, really understand their illness. We want to ensure that the care instructions aren't too general, because that can be a concern for some patients as they transition home. And then patients and caregivers sometimes wish that they were more assertive in the discharge process. They feel like oftentimes they should have asked more questions, more clarifying questions. Even after they get home, oftentimes they might think of questions but don't always take the initiative to reach out to their provider to ask questions, which of course can put the older adult at risk of a readmission if they're their lack of knowledge or understanding is impacting the care that they're providing, the support that they're providing. And new diagnoses, of course, can pose special challenges. That new diagnosis might be overwhelming. The patient might want more information. They might want more one-on-one time with their provider, more hands-on training, more follow-up, so that again, they fully understand that new diagnosis and they know family knows how to provide sufficient care upon returning home or support that individual in that new illness. And then sometimes older adults might feel that their primary care physician is missing from that whole transition. So they might feel that they saw a number of healthcare professionals in the healthcare or time that they were in the hospital, but it might not have been communicated to their primary physician or their regular specialist. So again, want to make sure that that line of communication is there. And then some older adults have only limited or no support at home. We've talked again about how important that can be. Single or divorced individuals are more likely to return home alone, and they might be too weak to care for themselves. So it's something that we need to be mindful of. And then some feel that they're not ready to discharge. So while we have those who are itching to get out of the hospital, some feel that they are discharged too soon and they don't feel like they will be able to make that transition successfully. So we need to walk patients through the options for support, possible options for rehab, and so forth. And that follow-up care is so important, again, to reducing those readmissions. So sometimes patients are confused about who they need to see for follow-up care, especially if their general practitioner, their primary doctor is outside of the hospital system that they're transitioning home from. They might be confused. Do I have to go back to the same hospital system, or can I go see my regular provider? So we want to make sure, again, that those types of things are clearly communicated. And then there's some additional drivers here that kind of sum up the two, the patient perspective and the doctor perspective, or the provider's perspective, pardon me. So we know that chronic conditions and patient illness can, of course, impact that transition home and possible readmission. Communication issues amongst patients and families and their providers can be a driver for readmissions. Want to make sure that those medications are clearly communicated. Want to make sure that there's coordination among clinicians, especially in those care facilities that they transition to. And then want to make sure that they're really understanding the availability of hospital care after they transition home. And some again have to transition to a rehab facility, a post-acute facility, and in some communities, I know in my community, oftentimes those places have long wait lists, especially in certain areas of the city. So we want to make sure that we're communicating all of the options for that support post-discharge. And if family members are not part of the discharge planning process, it can be a driver for readmissions. So again, these are really important to keep in the back of our minds as we're working with patients in the discharge process and that transition home. So we've been talking a lot about readmissions, but I just wanted to briefly touch on the hospital readmission reduction program. That's really where all of this hot topic comes about. So when we talk about readmissions, we know that this hospital readmission reduction program has been kind of the driving force behind hospital systems across the U.S., really putting a focus, a spotlight on this topic. So when we look at this chart here, this chart shows over the years, so this hospital readmission reduction program, has been implemented in waves. And so at the top of the chart, you'll see the years and performance measurement periods, and then the diagnoses of initial hospitalization. So most recently in 2017, uh, coronary artery bypass graph was added to the diagnosis of initial hospitalization that this hospital readmission reduction program implemented, and then pneumonia was expanded. So if we look at the penalties that hospitals have experienced over the years in these various categories, we see that on the second line there, it shows the percentage of hospitals that have been penalized in the U.S. And you can see that those percentages increased from 2014 to 2015. And that's really due to several of those new diagnosis categories. It took hospitals a little bit to put strategies in place to make an effort to reduce readmissions in those areas. But that number has stayed fairly consistent. And again, in 2017, there was the addition of coronary artery bypass graft and the expansion of pneumonia. And so on that bottom line, you can see the penalties that are estimated by CMS for this hospital readmission reduction program. And it helps at times to see these figures in graph form broken down by the various disease states. So the diagnosis is. So these graphs, I apologize if they're a little hard to see. Hopefully you can download the slides and zoom in a little bit, or you can find these online as well. But these graphs show the readmission rates from 2010 to 2015. So you'll see that the red line are Medicaid readmission rates. The green line is Medicare readmission rates, and the blue line is private insurance. And so the top graph shows acute myocardial infarction in the 65-plus population. The top right shows us heart failure readmission rates, and the bottom left is pneumonia readmission rates. Now, the bottom right shows readmission rates for non-targeted conditions. So that would be readmissions that occur that were not on that graph or that chart that I showed you on the last slide. So those would be things outside of heart attack, heart failure, pneumonia, COPD, hip and knee replacements, and CABG. So if we look, things are trending in the right direction. There is a reduction in these hospital readmission rates, more so even than those non-targeted conditions. So we know that hospital systems are really targeting those specific diagnoses, and they are making an impact. And so again, this topic is very timely and important when we're talking about that transition home. And then I just wanted to share one more graph with you. The bottom line on this graph with the triangles, it shows the potentially preventable readmissions. So you can see how over time, what I like about this graph is it kind of breaks it up. So you can see that between 2008 and 2010, that was before the hospital readmission reduction program was implemented. And then there was a time span where the Patient Protection and Affordable Care Act was passed and gave hospitals a few years to prepare for the hospital readmission reduction program before penalties kicked in. But then you can see from 2012 to 2016, there's been a decrease in those preventable readmissions, which is, again, a sign that hospital systems across the nation are making improvements in these areas. So we talked about readmissions and the drivers behind them. Now I really want to shift the conversation to talk about how we can help patients and families plan ahead for that transition home from the hospital. When older patients return home from the hospital, it's oftentimes the little things that can often get overlooked. The older adult is sent home again with those detailed discharge plans containing important information and instructions for the patient and their families. However, families might not anticipate all the additional tasks that will be required of them to help make their aging loved one's transition home a smooth one. When considering assistance, an older adult when considering assistance that an older adult might need after being hospitalized, there's really 4 key areas that may require caregivers to assume more responsibility, more time, more effort than their normal day-to-day interactions with their aging loved one. And many of these activities, if a family member is not available to assist, could be delegated to home care professionals or home health services. So I've broken these down into 4 categories, and we're going to start with healthcare tasks. So family members are often overwhelmed and overcome by the wide range of caregiving-related responsibilities and activities. And this might be due, again, to that lack of time in their busy schedules, lack of confidence in their own caregiving skills, or the inability to provide for these needs. We know that family caregivers are being asked to do more and more medical tasks. And sometimes this can result, especially if the family member feels that they're unprepared or do not have time to assist their loved one, it could result in missed follow-up appointments, medication mismanagement, and that readmission to the hospital. So it's really important for family members to review that discharge plan or care plan and ask important questions. And later on, I'm going to share some categories of questions that caregivers should be asking as they review the discharge plan or take part in the discharge process with their loved one. And as professionals, we want to definitely encourage them that there's no such thing as a silly question. We need to make sure that they're feeling comfortable in asking about the discharge plan with the hopes that if we're able to answer those questions, it can hopefully help that family member in that transition home. They might also feel uncomfortable with changing dressing. So wound dressings, that kind of task sometimes can be intimidating. We also know that vital signs are important to monitor after hospitalizations, especially for certain conditions. So we want to make sure that family members know the acceptable or expected ranges or the healthy ranges for the various vital signs. And then we need to let them know when that vital sign becomes a red flag, and most importantly, who to contact if those red flags appear. So, for example, if a family member is taking a vital sign and it exceeds the threshold that they were instructed during their discharge plan, that family caregiver should know, call your primary care physician first and alert them of this issue, and then go from there instead of rushing your loved one to the ER. So I want to make sure that family members know who to contact, again, to hopefully avoid that readmission to the hospital if it is unnecessary. Many families members also they don't have a medical background. Some do, but many do not. So we, again, need to make sure that they understand how to operate or adjust medical equipment, how to take those vital signs, and also how to assist their loved one with personal hygiene. So oftentimes family caregivers feel uncomfortable helping their loved one with those types of activities. So we could suggest resources such as trained professional caregivers or resources that they can go to learn how to better provide those types of care to their loved one. And then we want to make sure that family members, again, understand the proper follow-up care that is needed and help them maintain those schedules of health visits and appointments in order to make sure that those appointments take place and, again, reduce the risk of hospitalization. So the next category is the medication management. Medication plays a big role in readmissions, as I mentioned earlier. Medications can sometimes be confusing. Again, if the older adult is used to taking only 1 or 2 medications and all of a sudden they return home from the hospital with a longer list, they might be confused as to whether or not they stop taking the old medication and just take the new meds on the list and so forth. So we want to make sure that older adults and their family caregivers really understand that medication list. And patients might also be inadvertently discontinuing medications that they need to stay on because of that confusion. They might not They might also not have the right prescriptions at home, or they might not have the ability to refill them. So again, those are some things we need to keep in mind. And sometimes they'll stop taking a medication due to the side effects, or family members might think that, if my loved one's symptoms clear up, that means that they don't need to continue taking that medication. And we know with some medications, they need to take the full prescribed days of medication, regardless of whether or not those symptoms have cleared up. So those are the types of things we want to make sure are being communicated. And when it comes to the family caregiver, you'll see listed here some of the things that they might have to do to help their loved one with compliance as it relates to medication. So they might have to order and pick up those prescriptions and refills, and ideally before their loved one gets home. Understand the labels and the instructions, those expiration dates, administer the medications at the right time, monitor those side effects. It can be helpful for family caregivers to use a little journal to keep record. Store medication properly, safely, especially if it has to be refrigerated. Help maintain that medication schedule or medication tracking system. Especially in terms of pain medication. I recently had a loved one who had a procedure, and we had a kind of a written schedule on the kitchen counter. Every time that individual took pain medication, we'd write down the time and then the time they needed to take the next dose, just to help everyone that was kind of rotating in and out to help with that individual's recovery. They would all know the medication schedule. So those little tips can really help families be able to help their loved one manage the medication. And then there's also tasks around the house that have to be managed. Oftentimes, an older adult has been away from home for several days, weeks, or even months. So there are several things that families can do to help with that household environment. Of course, they want to ensure the safety of the environment. So family members can do a little home safety check, make sure that the pathways are clear. If grab bars need to be installed, make sure that that takes place as an example. And then they also need to check the refrigerator for outdated and spoiled foods before that person comes home from the hospital. And this is really important because food poisoning certainly needs to be avoided. So it might be, again, something that the family member might not automatically think of, but we definitely want to make sure that that fridge is cleared out, and then it's restocked with fresh items so that we can ensure that the nutrition of the older adult is conducive to their recovery as well. And family caregivers might be tasked with preparing special meals. Perhaps they come home and they now need to eat a low sodium diet, or the individual has to be on a liquid diet for a short period of time. So family members might be required for that. There might be other shopping needs, household goods, supplies, those sorts of things that need to be purchased on an ongoing basis. And then also the family member might need to manage that schedule and communication with those visiting healthcare professionals. Maybe it's home health, the occupational therapist, physical therapist, maybe it's home care professionals. So family members can help with the managing and coordinating of all those schedules. And then a lot of times durable medical equipment, as we know, is recommended after a discharge from the hospital. So family members can help in arranging that as well. And then the final area is family communication. And we know I've been talking a lot about how crucial communication is in this whole process. And this is especially true after the discharge home or after the transition home from the hospital. So family members can help maintain emergency and medical contact lists. They can communicate with other members of the family and the healthcare team. They can help with bill pay, assist with mail, those kind of paper correspondence. They can provide instructions and training to other family members who are helping out, especially if there's that one family member that was there during the discharge process and were instructed on how to change the wound dressing or that sort of thing. They need to be able to communicate that on to other members of the family that are helping with care. And then family members can help assemble and keep records of important documents, the discharge plan, the advance directive, living will, and those sorts of things. we've been talking about how crucial this support system is for an older adult and that successful transition home. And it really is true. That support system is vital to preventing those readmissions. So when we talk about a support system at home, we want to help determine, how long is support needed? Is it just a few days or weeks, or will they need support ongoing? And when is care most important? Perhaps the older adult is okay by themselves during the middle of the day, but really need assistance getting up and going to bed in the evening. So really working with that family and the senior to understand the support that is needed. Oftentimes I would find the older adults I worked with would need really around-the-clock care in the first days or weeks after a transition home, and then that schedule really was modified as they continued to regain their strength or recover from whatever procedure they had. And we know that family members aren't always available to help, so we, as professionals, can help older adults find those additional support services. And two common support services that are recommended at a transition home are home health and home care. So we know home health is a service that a lot of times is paid for by Medicare during a transition home or post-acute, but it's only covered for a short period of time in most cases. And then home care is another means of support that is not covered by Medicare. It's primarily covered by private pay or long-term care insurance. So we're going to look quickly at both of these types of care. So we talked about how home health care comes in for more of that shorter period of time. So they are likely to focus mostly on those medical tasks. And typically they come for about an hour or so a day or on the days where they're providing their service. So some examples would be OT, PT, wound care. They might assist with IV therapy and those sorts of things. And oftentimes there is a certified healthcare professional that is providing those home health services. And that compares, as we compare it to home care, home care can really be there for those remaining 23 hours of the day that home health is not there. So if an older adult does not have family to assist, or again, perhaps the family is working during a period of the day, or the family is long distance, having home care can be that support for those various examples of things, as you can see, that can really be vital to reducing those readmissions. Home care can help reinforce that plan of care. They can be that extra set of eyes and ears in the home. So they can help with, those medication reminders, nutrition, hydration, transportation to those really important follow-up appointments, and so forth. And the age-old question is, how are these services paid for? As I mentioned earlier, primarily home care is paid privately or through long-term care insurance. There are some veterans assistance benefits that might cover home care in certain situations. And then for some who qualify for Medicaid, there might be a benefit for home health, such as a bath aid or even homemaker services. So the local area agencies on aging can help find those types of services too. And I'll share more information on the resource slide. We do know that Medicare Advantage plans have started to look at covering home care. Many have not implemented that. A few are starting to kind of test it out. So it's most likely that Medicare Advantage does not cover home care, but it is an option to look into as more Medicare Advantage plans look at the option of adding a home care benefit. So this is all great information, but it can sometimes, again, be overwhelming to families. I was just reading an article today about a family caregiver who she's a working professional, and her mom had an incident that landed her in the hospital, and all of a sudden her world was flipped upside down. There was 5 million things she felt like were added to her to-do list. It was very overwhelming. So I wanted to kind of break all of this down into some easy steps that families can take as their loved one transitions home. So we're going to look at each of these steps. And we're going to start by talking about things that that family members can do before before their loved one even leaves the hospital. And the first one is, those important questions to ask. So planning for a smooth transition back home can really begin as soon as the individual enters the hospital by asking a lot of questions. So these questions can be asked, of course, of the medical team. A lot of hospital systems have, again, that multidisciplinary team. And instead of listing out exact questions, I wanted to kind of more so break it down into categories of questions that families can ask. So definitely want to ask about the lengths of stay, any constraints that their loved one will have related to their illness or reason for hospitalization. What are the dietary medication concerns that we should have? What kind of follow-up is required? What are the warning signs we need to look out for? And so forth. So those are, again, some important questions to ask. But then it's really important to prepare the home before the individual even makes the transition. So I touched on a lot of this earlier, but making sure the medical equipment is delivered, making sure the medications are there, discussions with the pharmacist, arranging those transportation to medical follow-up appointments, making sure that the food the spoiled food is discarded and new foods are brought to the home, and even changing bed linens. That's not something you might think of, but again, if the older adult has been away from the hospital from an extended period of time, a fresh set of sheets can do wonders upon that return home. And all of these tips, all these steps, I should say, are in a booklet that we can share with families called Returning Home, and I'm going to share that with you in just a bit. But it also has a discharge checklist that is part of the guide, and so I thought I would share that on the next two slides. But again, I'll give you a link to where this resource can be downloaded and shared with families. But sometimes it's very helpful to have a list where family members can check off each to-do on the to-do list as they go about planning for that discharge or that transition home. So, again, these are some things that we've already gone over, but just want to give you as professionals tools and resources so that you can pass them along to families so that they can help with that smooth transition home and hopefully prevent a readmission. So some of the additional checklist items are here. Again, a lot of these seem simple. They might sound like I'm stating the obvious, but if you've ever been in a crisis situation or under a lot of pressure, sometimes you can forget to ask certain questions or you can fail to get the right information. And so having a checklist like this can be really helpful when you're under that stressful situation. And then as we look to the next slide, we're going to talk about what family members can look for when their loved one actually gets home. So those first few hours and days back at home are the most crucial. This is when family members can watch for those important warning signs to ensure that their loved one's condition is not out of control. Pardon me. It's also a good idea for family members to keep that daily record of medications taken. It can even be helpful to jot down what they've eaten and how much, what times of the day, activities that they're doing, any assistance that is being provided. That way, if for some reason there is a warning sign that appears and a call is made to a healthcare provider, they're going to ask a lot of questions. When was the last time they took their medication? Have they eaten anything out of the ordinary? Those kinds of questions. And if a family member is keeping record of all that, that information can be right at their fingertips. And for caregivers, it's really important during those first 30 days to ensure that those plans or that plan of care is followed out, those follow-up doctor's appointments and rehab appointments are happening, making sure that they're eating well, that those medications are being taken, and that they're again following those necessary steps to avoid that readmission. And then when, when a warning sign appears, sometimes it can be hard for families to know what to do. And we talked a lot about how it's really important to communicate, who should they call? Is it the family doctor or primary care doctor, or is a call, emergency call warranted? So this can kind of help family members break down the differences, but of course it's likely to be specific to their condition or their reason for hospitalization. But just to give you some ideas, you know, a call to a family physician or a general practitioner would be warranted for things such as a lack of bowel movement, new skin issues, a change in balance or coordination, a change in their mental status or behavior, ineffective pain management, nausea, vomiting, diarrhea, medication issues, maybe those side effects, and some of these kind of warning signs could be side effects of the medications if they're having dizziness or a fever. And then, important warning signs from when an emergency call is likely necessary if they have a fall, especially with bleeding or a broken bone, severe or prolonged bleeding, that severe or prolonged pain, if you're unable to wake the older adult, of course, an onset of slurred speech, sudden weakness, chest pain, and increased difficulty breathing. So again, if we can give families these kind of general warning signs, or even better if we can give them specific warning signs related to their condition, that can help them make decisions kind of in those times where they might be unsure. Do I need to take my loved one into the hospital, which would be a readmission, or is this something that we can go to the general practitioner with, or the designated follow-up clinician with these questions to avoid that readmission? So I've been mentioning that there is a resource that you can download. It's called Returning Home. There's a whole website built around it. It's returninghome.com. And this is a great website, a great tool. You can download the Returning Home Guide. You can see that right there in the middle. It's a PDF, so you can email it out to families or print copies, as many as you would like. But that guide has the checklist and also a lot of the great information that I've shared today. On the website, there's also transitional care videos. You can also download a senior emergency kit that can help families compile all those really important documents. There's also a home safety checklist. So when older adults are transitioning home, the family is wanting to kind of do a once-over of the house to see if anything needs to be modified, if any new safety concerns have arisen since they've been home last. That home safety checklist goes through the house room by room, so that can be really helpful. And all of that can be accessed again at returninghome.com. Some additional resources for family caregivers, a great general resource is caregiverstress.com. If a medication management system is necessary, a great option is Simple Meds. So the website is simplemedsrx.com. For those that are homebound, that perhaps their family isn't around and they would benefit from a home-delivered meal program. A lot of area agencies on aging offer home-delivered meal programs, but there are some outside of those agencies, and so you can do a zip code search on mealsonwheelsamerica.org. That's a great resource. You can type in, again, their zip code and find the local meal delivery program. And oftentimes they can offer a low sodium option, again, if those dietary needs are of concern. And then the area agencies on aging can be a great resource for families. You can, again, do a zip code search at n4a.org. And then some communities do have a PACE program for those that have a limited income. And so that a lot of times is a great resource for individuals. And again, you can find your local PACE program, a zip code search. Everything's kind of based on zip code, but there is the website npaonline.org where you can find more information. Again, that's only available in some markets, but the area agencies on aging cover all of the United States. So you should have one that is somewhat near your patient or your family member. So again, a great resource. so with that, I will open it up for questions. And I thank you all so much for listening today and for joining me on this important topic. And hopefully we can help those older patients that we work with that transition home and help family caregivers feel empowered to be that support system. And when that support system is not there, hopefully we can help the older adult find resources, whether it's home health care, or the Meals on Wheels program in their area and so forth. So with that, I'll throw it back over to you, Steve.
All right. Thank you very much, Lakeland. Okay, everyone, it's time for the Q&A portion of this webinar, so send in those questions right now. And let's jump right into it here, Lakeland. First one for you. Did you say that regulations or laws were recently put into place regarding hospital readmissions? Can you talk a little bit more about that?
The hospital readmission, the acronym always trips me up every time. So the Hospital Readmission Reduction Program came about from the Patient Protection and Affordable Care Act. So that penalizes hospitals if they have patients that are readmitted to the hospital within there's a 30, 60, 90-day windows. And so hospitals can be penalized if an older adult was in their hospital system and discharges, but then returns to the hospital within that window of time. And even if they return to a different hospital, they might be penalized. So it's a very complicated kind of program. It was implemented in phases, so I apologize for not explaining that better earlier. Those charts were probably a little confusing if this is your first introduction to it. But there are various conditions that they target, various diagnoses of the initial hospitalization. So if an individual was hospitalized for COPD or hospitalized for a heart attack, that chart that I showed you, I think it was slide 11, 10 and 11, those are the targeted diagnoses that they will penalize for if that older adult is rehospitalized. So hospital systems are trying to find ways to reduce hospital readmissions for those patients, and they're doing that in a lot of different ways. They're getting creative. They're putting resources into that follow-up process. So if your loved one is in the hospital system and is discharged home, you might find that there is a little more support from the hospital system in terms of follow-up calls, transportation back to the hospital. I know some hospital systems are offering transportation now to, again, make sure that their patients are getting those follow-up appointments and not going to the ER for things that they could be treated for in the clinic setting and that sort of thing. So I hope that is helpful. The CMS website, Centers for Medicare and Medicaid, the CMS website has more information if you really want to dive deep into that. But that's a good question.
Okay, next question, Lakeland. A large number of these patients do not have a support system. What is being done at this point to address that, especially as it relates to preventing readmissions?
That is so true. While there are millions of family caregivers out there supporting their loved ones, there are many that do not have that support system. So hospital systems are, again, getting creative. Actually, Home Instead has done some pilots with hospital systems across the nation where some hospital systems are starting to cover some of the support care that's needed to help with that successful transition. Again, they're starting to offer things like transportation or making more follow-up calls. Some have kind of more of a designated person within the hospital system that is assigned to a patient where they're helping to monitor that follow-up care, especially with those patients who might be at a higher risk for a readmission. So there's a variety of things that are being done, and it really kind of varies from hospital system to hospital system. But that is an issue, and that's where those the various supports, I know not everyone can always afford, home care services, but a lot of times home health can come in a lot of times can be covered by Medicare, but getting those older adults connected with as many resources in their community as possible will hopefully help with that successful transition. So again, those Meals on Wheels programs, some area agencies on aging have homemaker services or bath aids that can also go out. So again, connecting them with as many resources as possible. But that is an issue and one that many hospital systems are working to solve. So thank you for that question.
All right. Well, Lakeland, we are just about out of time here. We've reached the end of our hour, but thank you for joining us today for a great presentation.
Thank you. Have a great day, everyone.